Welcome, I'm Dr. Robert Glatter, medical advisor for Medscape Emergency Medicine. Joining me today is Dr. Robert Pearl, plastic and reconstructive surgeon, faculty at Stanford Graduate School of Business, and former CEO of the Permanente Medical Group, to discuss his recent Forbes article, How America Skimps on Healthcare, also known as Shrinkflation. Welcome, Robert. It's really a pleasure to have you join us today.
Hey, Rob. It's a great pleasure to be here.
So, first of all, the article basically deals with a concept known as shrinkflation. I want you to define that for us, for our audience, if you could, please.
A great way to start with an example. About a month ago, I went to the store and purchased some cereal. I want to have some fiber in my diet. And I opened the package and it was only 3/4 full. And it wasn't a manufacturing error. It was intentional. And what happens is that at times of major inflation, businesses raise their prices, earn either added profit or at least maintain their profit, despite the fact they might have some higher supply costs. And then at some point, the consumer says, I just can't spend this much. I can't spend $6 for a box that used to be $4. And so the manufacturer can't keep raising the price. So what do? They keep the $6 price because the consumer has already said, I can do $6, but just no more. And they shrink the amount of cereal, potato chips, soda. It doesn't matter what the area is. It shrinks the amount in order to keep the business producing it both viable and profitable.
How would that apply in healthcare specifically? And how can you translate that in terms of the corporate industries of packaged goods?
As I look to healthcare inflation, because remember, it's inflation that's driving this entire process, with the passage of Medicare and Medicaid in the mid-1960s, as well as some other changes in healthcare coverage, you see healthcare as a percentage of gross domestic product rising, not each year, that fluctuates, but each decade, so that by the time we reach 2000, it's already about 13-14%. And by 2010, it hit 17.2%. And I, along with most healthcare policy experts, think that it's going to get past 20% by the time we get to 2023. Lo and behold, it's not. And so I look at this and I say, why did it change? Was it Obamacare? No, because we didn't see any improvement in clinical outcomes. In fact, what we've seen is life expectancy decline from 78 years down to 77 years. We've seen other problems occur in medicine. No, what I realized is that healthcare has done the same thing that the manufacturers of cereal did, which is that it used shrinkflation. And by that, I mean you don't notice, or at least not very many people notice the changes. And I'm happy to go into each of them in detail if you would like me to.
Yeah, I would love that. We notice these changes. And certainly, I'm sure both you and myself have over the decades we've practiced. High deductible healthcare plans, you mentioned that in your article. And I think that's an important aspect of this shrinkflation. Maybe you could describe that a little bit more.
Around 2010, insurers started offering high deductible health plans. Well, what happened is that a business, and remember that the commercial private insurance, for the most part, is bought by companies that provide it to their workers. And they said, we just can't provide anymore. You may remember that we had a recession, 2008, 2009 in the country. And insurers said, we can keep the price that the employer pays by being able to offer these high deductible plans, which essentially said before your insurance kicks in, you as a patient have to pay a certain amount of money. And as that money went up from 500 to 1,000, 2,000, now it's as high as 5, 6, 7,000 for some people, what happens is that care gets restricted because you can't afford to pay it out of pocket. The average person doesn't have $5,000, $6,000, $7,000 in savings. They'd have to borrow against their house or do something else that would be pretty negative. And so instead what they do is they just skip getting their care. This is the shrinkflation that we see and why shrinkflation works. It's like the cereal again in the box. If you don't have serious illness, and the majority of Americans don't, then you don't see that high deductible until, of course, you develop cancer, get into a car accident, or some other reason need to have hospitalization. And then all of a sudden, you have a massive bill that, as you well know, healthcare is the #1 cause of bankruptcy in the United States.
Right. You mentioned in your article about 50% of Americans have medical debt. That's a real issue. Now, we're getting back to healthcare in terms of preventive healthcare, colonoscopies, cervical cancer screening, mammograms. That care should be covered, and that traditionally has been covered in health plans.
Some of that is covered, but as you well know, if you're having, in quotes, a purely diagnostic colonoscopy, it's covered. But if you happen to have polyps, then that's not covered. And so we have situations in which patients have to pay money to get care that you and I would think about as being preventive. Or if you have chronic disease and you need to have a variety of tests and interventions done in order to avoid the very expensive and serious life-threatening complications like heart attacks, strokes, cancer from a combination of diabetes, hypertension, obesity, asthma. These are the kinds of situations that we think as clinicians as being prevention, but from the patient's standpoint, it's an out-of-pocket expense, it's in the deductible, and they just say, I simply can't do those things.
And getting back to your point, I guess this extends also to trying to deny care through efforts such as prior authorization, hoops to jump through that patients can't get the care. Physicians are really exasperated trying to reach out to peers at healthcare insurance companies to get this care for their patients. So it leads to a vicious cycle of exhaustion, exasperation, and then patients give up, and certainly then outcomes worsen.
You're raising a couple of very important points. But often the clinician will say, well, I'm just not going to order this. It's just too much hassle to be able to get the MRI or the CT that's necessary. That lowers cost, but if it's an indicated procedure, it also compromises outcomes, may lead to some medical errors. I see it in being in two areas. One, the one you mentioned, which is prior authorization, which we know is growing in intensity and is certainly the #1 way that the insurer tries to keep costs down. And number two, we see it in Medicaid. Most listeners may and viewers may not recognize 90 million Americans are on Medicaid. That's more than 1 in 4 Americans in the program designed for individuals at a poverty level. And patients who have Medicaid coverage may look like they have full insurance. They just can't get a doctor. There's no primary care physicians in the area where I'm living right now willing to take on patients with Medicaid. And when they need to have an expensive procedure or a test, there's a lot of facilities that either will not do it or will delay it. If you happen not to be poor, you don't notice that Medicaid is doing this. And if you don't need a expensive procedure, then you also don't notice it. So these are the various ways that healthcare, I like the phrase shrinkflation, because it's reduced quality, it's reduced access, it's less of a high-value product, but the majority of people don't see it in any given year, and so the companies can get away with doing it and doing it more and more frequently.
This all translates really to outcomes, healthcare outcomes, which is really the end result of these processes you described. Looking at maternal mortality, longevity, rates of colon cancer, lung cancer, what are we seeing now as a result of this experiment, these acts of limiting and denying care?
Well, as you point out, the outcomes in the United States are quite problematic. When we compare the United States to the other 12 most industrialized and wealthy countries of the world, we're talking about England and France and Australia and Canada, what we're looking at is that we have a cost that is nearly double most of these countries. It's certainly by far the highest in the world. And we are last in outcomes. As you say, we're last in longevity. We're now nearly 6 years behind the leading countries, and our mortality has gone down. We did see a major drop prior to COVID. We saw a slight recovery last year, but the United States was the slowest country to recover. We lost over 2 years during the pandemic, and we recovered maybe 1 year. Other countries either lost a fraction of one or actually stayed level or increased, comparing now to 2-3 years into the past. Maternal mortality in the United States is not only the highest in these peer nations of the world, but we're the only country in which it's increasing, not going down. In fact, our maternal mortality is twice as high as the second most problematic nation, which is France, and 10 times as high as countries in Scandinavia. These are all aspects of skimflation. Patients are simply not getting the care when it comes to maternal mortality. And by the way, we're also the worst in infant mortality. A lot of it has to do with the prenatal care, which in the United States is often skipped, or the postnatal care, the early care for the mom following delivery, which is also something that is quite problematic. When you come to the overall longevity, we can look at chronic disease and complications from it. There's so many opportunities that exist, and yet our nation doesn't achieve them. And I fear that we're actually getting worse, not better.
I agree. And my thought is that maybe some of this large healthcare system consolidation that's been happening in the last several decades is part of the reason. Within cities and urban areas, you've got now maybe 2 or 3 major healthcare systems.
This is part of the formation of monopolies for market control. We see it among insurers. We see it among hospitals. We're seeing it increasingly with private equity. We certainly see in the drug industry. What we're seeing is that every part of healthcare, rather than moving forward to transform care, to achieve higher quality and better service as the driver of affordability, and I'll also say as a means to lower burnout, we're seeing us go into the opposite direction. So yes, this is quite the problem that our nation is facing, and we're getting worse, not better.
So how do we decouple this consolidation, so to speak? How do we, in other words, undo what, again, may be part of the issue, but not all of the issue? Is there any solution to that or fix?
I can offer my own view, which is that the fundamental problem is the fee-for-service system of payment in the United States today. Charlie Munger, who died a couple of weeks ago, used to say, tell me your incentives and I'll tell you the outcomes you're going to get. I think that if we can move, and I'm talking about the delivery system, not the insurance level, the delivery system to a capitated form, I have tremendous confidence in our clinicians and our doctors and our nurses that we can find the best ways to provide that care. Because as soon as you're capitated, you align the incentives of the people providing the care and the ones receiving it. Preventing disease, avoiding chronic disease in the first place, lowers costs and improves health outcome. Better treating chronic disease avoids the complications that exist. Being able to be capitated, you do better with higher patient safety, fewer medical errors, reduced misdiagnoses, better investments in the technology that actually extend patients' lives, a commitment to lifestyle medicine. The list goes on. And I have fear that if we don't find a way to be able to shift the reimbursement methodology, that despite all of the talk about value-based care and all of us knowing the right outcome, the best way to provide care, it's not going to happen.
Right. I agree. I mean, how do you disrupt then the large insurance industry as sort of the gorilla or the elephant in the room?
Well, what you and I both lament is that the individual patient has little control over this. One source of possible change are the payers, the employers who provide the commercial care, either self-funded, which is half of commercial insurance, or a more comprehensive traditional insurance program. And they could demand that these companies provide a capitated form, a prepaid form for a population of patients based upon the risk that the individuals have. And they have the ability to accomplish that, particularly the self-funded businesses that exist. The government could certainly lead the way and force this to happen, to make it a required alternative to the traditional fee-for-service model. I fear that neither is going to do it, either because they don't have the courage, the employer in the face of a very tight labor market, or for the government for the political reasons that exist. And as you know, I've written extensively that I think someone from outside the industry, Clay Christensen, has talked about this. Disruptive change rarely comes from inside. Kodak had the filmless camera, but they refused to implement it for a lot of self-serving reasons. And so Apple and others came along and replaced Kodak, which barely exists today. I think the retail giants, Amazon, CVS, Walmart, are poised at actually moving into healthcare to make this happen. And if you look at what they're doing, their biggest focus right now is on Medicare Advantage, the one capitated form of healthcare in the United States today. They already have primary care. I mean, One Medical is part of Amazon, Oak Street is part of CVS, Walmart's about to acquire ChenMed. We're looking at a variety of ways in which they're then going to be able to take over healthcare and disrupt and eliminate some of these other large forces. I mean, we think of the insurers as being so big. We're talking about 3 of the nation's 6 largest businesses rapidly moving into healthcare. And I think they're not going to try to augment and supplement or complement it. They're actually going to completely replace it.
Yeah, your points are all well taken. You mentioned Medicare Advantage, and that's been a lucrative business for the insurers. And certainly the recent Cigna-Humana proposed merger had other issues behind it. I suspect that the small number of Medicare Advantage persons enrolled in Cigna might have been a role or some factor in collapse of at least some of that merger, because of certainly United has a huge amount of Medicare Advantage, as does Humana, and Cigna doesn't. And so I'm interested on your take on that.
Well, I think one of the drivers was the fact that, as you note, Humana is a leader in Medicare Advantage. Cigna is actually a leader in commercial. So bringing the two entities together from a theoretical basis gives them a broader population to serve. And of course, the doctors providing the care provided to both populations. And so it simplifies the negotiating process and adds leverage. I actually think, though, the bigger reason that they wanted to do it was to compete with companies like United, that is so much larger than they are, that they control so much of the marketplace sitting in place. I don't know why they decided to end it, but I think the fear of regulatory oversight was probably a major piece sitting there. But I want to stress, Medicare Advantage today, outside of a few organizations, is not a capitated program. It's capitated at the insurance level, but it's still paid for the most part at the delivery system level on a fee-for-service basis. Yes, there's a small amount of incentives for doing more screening or some other small change, but it's a minuscule part that doesn't really impact the performance that sits in place. And I am not talking about capitation at the insurance level. It has all of the problems. Why? Because the insurer can't change healthcare delivery. What the insurer does is use restrictive prior authorization requirements. And we just saw this with the expanded use of generative AI to be able to make it easier, more frequent to reject these. And it doesn't have to win in the end. All it has to do, as we pointed out, is to create a barrier. And doctors and patients will slowly diminish the amount of expensive care, often life-saving care, that they want to pursue. I'm talking about at the delivery system level, and I hope that physicians are going to lead the way, putting together the kinds of groups capable of accepting capitation and working together around collaboration, cooperation, finding the right technology, not buying operative robots that increase the cost, take longer to perform a procedure, and fail to have any significant improvement in outcomes. I'm talking about using technology, whether it's telemedicine, whether it's ChatGPT and generative AI, whether it's all the other tools that we could do if we work together as one, rather than either on a fragmented basis or, unfortunately, what's happening today, even as more employees of for-profit entities who will simply find the ways to raise price in order to maximize the bottom line.
Right. And I think the bottom line is longevity. 2017, 2018's longevity versus 2010's, there really hasn't been much movement.
The best way to improve longevity is in primary care. Stanford and Harvard have done research that showed that adding 10 primary care physicians to a community increases longevity 2.5 times more than adding 10 specialists. And yet our nation continues to focus on specialty care. I mean, I'm a specialist. I love specialty. Don't get me wrong. But the foundation has to be primary care. And right now there's a crisis. We lost 71,000 physicians last year from the practice of medicine, of which the largest group was in primary care. If we're going to manage chronic disease, and again, you as a physician will know that in the last century, most of the problems we saw were acute. The ones you saw in the ER were trauma and maybe a heart attack. Now what we're seeing is chronic disease driving that all. Obesity, diabetes, hypertension. And you and I both know we could lower the incidence of those problems. In fact, research published by Kaiser Permanente has shown that 30% lower frequency of life-threatening MIs and a 30% improvement in lives saved is possible if you're able to invest in prevention, chronic disease management, hypertension, the number one cause of strokes in the United States. The second leading cause of kidney failure needs to be treated and can be treated effectively. When I was the CEO in Kaiser Permanente, we were over 90% of successful management of hypertension. The rest of the world is 50 to 60%. It's not that we don't know what to do. It's not that there's not something we can do. And it's not because doctors don't work incredibly hard. They work too hard. It's that the system and the incentives are broken in ways that make it impossible. And I think the 60% burnout rate simply reflects the imbalance between the demands and the time. A research study once showed that it would take 27 hours a day to do all the things that would improve the health of patients. We need to look to new tools, to generative AI, ChatGPT, other ways to be able to take the load off of clinicians. If not, I just don't see a very positive future. And I know what happens when you don't have a good alternative. Shrinkflation is a great example, or even overt rationing.
You think unionization of physicians in any way would help shift the balance or like move the needle, so to speak, about power? Is that going to have any bearing?
That is a great question. And unionization is certainly a way to gain power. But if you're not willing to use that power, then not only is it worthless, it's actually negative. And so if you're going to unionize, you got to be willing to strike. And you have to be willing to hurt patients. And I don't think that doctors will do that.
What about bargaining power other than striking? Wouldn't that collectively have a role? In other words, a show of force and bargaining through that aspect of that?
Well, the power of the bargaining is the ability to strike. Because if you're not willing to strike, then you're just sitting at the table for weeks and months after that. But I think it's actually more problematic even than that. If you're really going to bargain at the physician level, the challenge you have is, let's just say that you're a high-performing ER physician, and you can see 50% more patients than I can in a day. In a union structure, we make the same amount of money. How likely are you to be to lend your weight when you know it's going to reduce your income 25%, so mine can go up by 25%?
Yeah, point well taken.
Unionization overall has declined, as you well know. But if you look at where it's worked, like the auto workers, what you see is the willingness to strike and to harm the companies and its customers. And you also see salaries based only on longevity. It's not based upon performance. In fact, it very much dislikes performance measures. So I don't think that's the answer. I think the tremendous power that we have is in a negotiation, and we have it today in most communities, coming together, forming a medical group, taking a capitated rate. And then if you want to do a CT or an MRI, then you and your colleagues will have to look at the question and say, is it the right test to do? And that's how also I think we're going to diminish the disparities that happen between physicians. As you well know, there's a 4 times difference in CT for headache. Now, I don't know the right answer. I don't know if it's 1, 2, 3, or 4, but I know it's not 4 different numbers that are 4 times different. And so why can't all ED physicians come together and develop what is optimal? You know, we're a scientific society. Why can't we embrace science? I think that that's a frailty that we have that I actually think is the bigger problem that exists.
Yeah, and medicine is an art. It's not just cookbook, as you know, and that there are variations on presentation, specifically in emergency medicine, nuances, subtleties that experience certainly speaks to. Everything doesn't necessarily fit into a box neatly and particularly in terms of patient care, as you know.
I would agree with you completely, but the question is what's inside the box and what's outside the box? And so can we all agree this 75% is in the box and this 25% is outside the box? We can all agree that certain EKG tracings are very worrisome. We can also say that other ones are not. How do we keep shrinking what's unknown? It's actually 3 parts. There's we know, we don't know, and here's the part where intuition is all we can rely on.
Yeah, the defensive aspect of medicine, and certainly with litigation, this drives a lot of cost. And this is really easily to argue, certainly when in this aspects of emergency medicine where you may be the last person to touch this patient in the sense that they get no further care. And if they didn't get that exam or screening or whatever it may be, there's that aspect. And so given that, that's another area that has to be addressed. We know this.
Absolutely. And as I say, in those areas, we all should agree that it's too dangerous. Even though we think it's a 1 in 50, 1 in 100 chance to not get a CT, we should all agree we should do it in order to protect our overall interest. But I also would add, and ED is an area where I know it's happened a lot, is private equity. What we saw is a massive spike in testing and procedures once private equity came in, particularly expensive ones, that were not driven by that force, that was simply driven by economics.
These are excellent points. And I want to thank you so much for your time. Dr. Perl has been quite informative.
Thank you so much. And I do believe that together we can once again make American medical care the best in the world. We owe it to our patients, we owe it to ourselves. And I encourage everyone to step forward and take the lead. Thank you so much.
My pleasure. Thank you again for joining us.